Now, I'd like to begin by acknowledging the traditional owners of and their custodians of the lands upon which we meet today. On behalf of the Centre for Policy Futures, I pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. So this seminar is part of the University of Queensland Centre for Policy Futures Policy Engagement Program, which brings together experts on policy priority topics to unpack complex issues for regulators and policymakers. Today, we will be exploring the policy challenges and opportunities that can arise with digital health services from a human rights perspective. We are going to hear from three experts. Sean Costello from the Queensland Human Rights Commission, Ryan Coe from the UQ Cybersecurity, and Claire Sullivan from the UQ Centre for Health Services Research on what they see as the policy futures of digital health and human rights. I'm going to be your moderator today, and for those who don't know me, my name is Dr. Amelia Radke, and I'm a postdoctoral research fellow in digital human rights here in the Centre for Policy Futures. So to get started, and jump right into it. Our first speaker is Sean Costello, who is the principal lawyer with the Queensland Human Rights Commission and a member of the Queensland Law Society Human Rights and Public Law Committee. He has extensive experience as a human rights lawyer and has published and presented on various human rights issues, such as the introduction of the Queensland Human Rights Act. And I'm just going to pass on my hosting to Sean, so he can share his screen. Okay, so that should be with you now, Sean.
Thanks, Amelia, and hello, everyone. Hopefully you can see my PowerPoint presentation, but you can't and see any of my notes. It's great to be here and be part of this. I'm lucky enough to go first and stress that I am not an expert in digital health. Thankfully, we have Claire and Ryan here who are going to give you much more interesting presentations. I'm going to sort of set the scene, I suppose in a slightly narrow way in terms of what the Queensland Human Rights Act provides in this space and pose some questions about how it might apply. There are, of course, international human rights. There are anti-discrimination and privacy protections across Australia as well that might be relevant. But I'm focusing today on the particular protection we have relatively recently in Queensland. I'd also like to begin by paying my respects to traditional owners of the land we meet on today and to elders past, present and emerging, and particularly acknowledge any Aboriginal and Torres Strait Islander people who may be with us today. And one of the things I'm going to briefly speak about today is the very particular cultural protection that Aboriginal and Torres Strait Islander people enjoy in the Queensland Human Rights Act. So as I said, I'm going to give you this background to what this Act is, how it might be relevant to the conversation we're going to have today, pose some quick questions along the way, including who has responsibilities in a digital health sense under the Act, how are they going to be relevant to our conversation, and in particular, this is a really interesting area in terms of how regulation and the promotion of digital health can both limit and promote rights depending on how we're viewing the particular technology or issues. So very quickly, the Human Rights Act aims, as you might expect, to promote and protect human rights and build a culture in the Queensland public sector. And that's going to be a really interesting theme for today. The focus of international human rights protection and protection in Australia has been on the public sector, on government, and I'll talk a little bit about what that means. But it is interesting in this space in terms of who does and may not have obligations. It's also trying to promote a dialogue of human rights and basically recognise that we're all inherently have inherent dignity and worthy of all human beings. So there are 21 sections of the Human Rights Act dealing with civil and political rights and 2 economic, social and cultural rights. I'm only going to pick out a few today. I just wanted to note for the purposes of introduction that there are a number of rights and within them there are a number of further protections. Those civil and political rights tend to be what we might understand in Western democracies as sort of the way the individual interacts with their governments. And that's tended to be the sorts of rights that are legislated across jurisdictions when they come to legislate international human rights. Economic and social and cultural rights are more unusual. And whilst the ACT has a right to education, for today's purposes, it's really interesting to note that the right to health is a unique economic, social and cultural right protected only in the Queensland Human Rights Act compared to those other jurisdictions. So, as I said, there's this idea of this dialogue model of human rights protection, and that all three Australian jurisdictions who have this legislation have adopted that sort of model. And the idea is each part of government has a different obligation, but there should be a discussion and dialogue between them and across the community about human rights. Today, I'm going to focus in on that bottom right-hand circle and talk about what the obligations are of public entities in particular. But just to very quickly note, Parliament's obligations are to think about human rights when it's making laws, and courts and tribunals then think about human rights in the way they interpret and enforce the law. So, as I said, we're focusing in on public entities, and basically there are three different forms of entities that might have obligations under the Human Rights Act. Core public entities, and really these are organisations and agencies, departments that we think about when we think of government, and they are going to have these obligations I'm going to speak about in a minute all the time in everything that they do. There's also this idea of functional public entities, and this is a concept where if government wants to outsource a function that you usually associate with government, that it's government's job to do, that the human rights obligations flow from that. And that's an interesting concept for some of the things we might talk about today. But the classic example that's often given is a prison. So running prisons is a classic government function, but if you were to outsource that function to a private entity, as has happened from time to time in Queensland, then the human rights obligations flow on to that entity when they're doing that function. And then finally, entities can opt in to being public entities if they choose. So I've just picked out some public entities that might be relevant for our conversation today: the Minister for Health, Queensland Health, hospital and health boards and the services they provide, like hospitals. They'll be core public entities. If Queensland Police wanted to seek access to a health record, for example, they would be a public entity. The Act also very specifically states that registered NDIS service providers in fulfilling those functions will be public entities. So they'll have the obligations I'm going to mention in a moment. And then we get through to the functional public entities. So where a private provider is funded by the Queensland government, like the MARTA, for example, then you would expect that when they're providing those public functions, that they would be a functional public entity. And similarly, where a private hospital might be treating public patients funded by the Queensland government, they might have those obligations. More interesting for today's purposes will be things like contracted IT providers. What function are they doing is going to be a really critical question in terms of whether the human rights obligations will flow to them. And I'm sure it's going to come up today, but probably you've already acknowledged or realised that when we talk about entities like Apple and Google, these big multinational entities, private entities, they almost certainly won't be, unless they're somehow contracted to do something for government, they're almost certainly not going to hold these obligations. So whilst some of those companies have, through their own initiative, taken on board international human rights obligations, as a rule, they generally won't be covered by things like the Queensland Human Rights Act. So I've mentioned a couple of times now there are different obligations. We talk about these sort of two obligations as being procedural and substantive. So there's a procedural obligation on public entities. So when they're deciding to make a decision, maybe they're thinking about regulating a particular part of digital health, they have to identify the rights that might be relevant to that, both in terms of the many individuals that may be impacted by that decision. Then once they've made their decision, when they come to act, they have to act compatibly with those human rights. The idea is that entities will try as much as they can when acting compatibly not to limit a human right at all. And when I say limit, this is a term human rights lawyers use. I suppose it's when you're impacting upon, touching upon, influencing an individual's protected human right. In a moment, I'll go through some that may be relevant in this space. But the idea is, if you can, don't touch upon it at all. But if you must, to achieve some important purpose, then that limitation has to be reasonable and demonstrably justified. And the idea is that public entities will do all they can to only limit rights to the minimum required to achieve some important purpose. And there's a bit of a cheat sheet. What we say to entities is what you're doing lawful? You need to have some lawful basis for it. Is it for a really important purpose? Are you actually going to achieve that purpose? Is it necessary? Is there a less restrictive way of doing it? And when you weigh all those things up, is it a fair, balanced, reasonable step that you're taking? And so you can see when entities are going through that proper consideration process, these are some of the things that we'd be expecting them to go through. So as I said, I've just picked out some of the rights in the Human Rights Act that can be relevant to the discussion we're going to have today. The right to privacy is actually quite a broader right than it might sound like. So certainly it will be relevant to things like confidential health records, but it can be quite a bit broader. And I've just included a quote there from Justice Bell in Victoria talking about how broad it can be. And you can see from the right itself, it's not just a person's privacy that it protects, but family, home, correspondence. And Justice Bell there has talked about individual identity, personal development, establish and develop meaningful social relationships. So in some ways, it's any sort of interference with a person's person or personal autonomy can engage this right. And certainly in jurisdictions that don't have a right to health like Queensland, often this is the right that can be most relevant to healthcare. So as I said, immediately apparent, it can be relevant to collection and access of health information and digital record. And there's a committee at the Australian Parliament whose job it is to scrutinise legislation. When they were looking at the My Health Record work that the Commonwealth did a few years back, they certainly identified this right as a really important right in terms of control and access to people's personal information. I'm sure that's something we'll talk about more today. Very quickly, there's a protection in Section 17 from torture, cruel, inhuman or degrading treatment. And even though that sounds a little scary in its title, it's got this very specific protection that's probably going to be relevant today, which is treatment without the person's full, free and informed consent. And this is probably one of those rights where we can flesh that out more in our discussion, but you could see how digital health could really have the potential to further protect and enhance this right by ensuring that the people understand fully what they are consenting to and that a record is made of that. Section 26 protects both the rights of family and children, particularly thinking here about the rights of children. And that's again something that the Parliamentary Committee looking at the My Health Record picked up on, because it includes the right for children to develop to their fullest, to express themselves on all matters affecting them, and to access healthcare to meet their needs. So really, the overarching test is acting in the best interests of the child. And when that committee first looked at the My Health Record, they had some concerns about the fact that really it wasn't until the age of 18 that a young person could really start to control their record. And I'm not quite sure what precipitated it, but looking more recently, it seems like the Commonwealth's changed its policy in that regard. So now it's 14 that a young person can take control of their health record and then determine who can and cannot have access to it. And so that change seems to me to be further protecting this right. That's a less restrictive way of achieving what the purpose of the digital record was, in a way that really fulfills many of these rights of children. Probably the right that's going to be most relevant in some ways to a lot of our discussion today is the right to equality, which is this quite broad right in terms of ensuring everyone has the right to enjoy their human rights without discrimination. And in the Queensland Human Rights Act, discrimination includes attributes that we might be quite familiar with in the Anti-Discrimination Act, but it can go beyond those as well. And we're sort of a little bit in the dark still as to what further attributes might be protected. I've picked out some there that are already probably protected under that right that might be relevant to the discussion. So certainly bodily integrity, autonomy and self-determination is really important for those born with non-normative sex characteristics, and Intersex Human Rights Australia has really noticed and noted the benefits and challenges of digital health for that cohort, because it may include information that some people will not be familiar with until they have access to the health record, but it also empowers them to control who has access to what may be very sensitive health information. There's also can be stigma attached to some health information, and the UN has put out some guidance, particular on the use of digital technologies in HIV and health, with that in mind. The Australian Human Rights Commission has also written quite a lot, and most recently last year, on human rights and technology, and the accessibility of technology to people with disability is a real focus of that report, and noting that generally all humans are assumed to have full decision-making capacity, but that's a really important concept for people with disability, and making sure that whatever technology is used respects that. And again, it's another example of something that probably can be further enhanced through the use of digital health. And finally, I've just noted that race can be relevant, most specifically in Queensland to Aboriginal and Torres Strait Islander peoples, perhaps. And certainly the UN has acknowledged that health services should be provided in a culturally appropriate way. And Section 28 of the Human Rights Act provides very specific protection for the cultural rights of Aboriginal and Torres Strait Islander people. The final right I was going to mention is the right to health. It's probably the one everyone's been waiting for me to get to. And the reason I followed from the right to equality with this right is it's got two protections. The first is that everyone has the right to health without discrimination. And that's the same definition as used in the right to equality. So again, we have those attributes under the Anti-Discrimination Act, but we could have some more as well. And so it's really interesting how this right may play out in Queensland. What sort of other attributes might be relevant to this discrimination? What about someone on country who wants to access a health service, particularly a digital health service that may only be available in other parts of the state? Could this right protect them? And then we have this other component to the right, which is a person may not be refused emergency treatment that's immediately necessary to save their life or prevent serious impairment. And that right is not subject to the discrimination test. So it could potentially be a more fulsome right depending on the circumstances. And there's a little bit of case law from South Africa about how that right applies, and it's sort of contrasting. So we have this 1988 case involving the application of the right to health to chronic renal illness, and it was found that the emergency treatment aspects of that right didn't extend in those circumstances to protect the patient. But in contrast, in 2015, a man was injured during a rugby game, and there was a 12-hour delay in transferring him around several smaller hospitals searching for treatment for his spinal injury. And in that situation, this emergency treatment protection was found to be enlivened and protected. And so, again, you can see how in Queensland that could be very relevant to people living in more remote areas of the state. But really looking forward to the discussion today. I hope that helps. I'll give Claire the hosting rights now. I've included some other resources there. We can share them afterwards around where there's been some discussion internationally and nationally on human rights and digital health.
Thank you so much, Sean. That was really brilliant. And I think it really highlights the types of issues that arise when it's not just a right to health, it also plays into other healths. And I think that's really great. So next, I have the great pleasure to introduce Associate Professor Claire Sullivan, who leads the Queensland Digital Health Research Network at the University of Queensland Centre for Health Services Research, along with being a clinical informatics director, the clinical informatics director at Metro North Hospital in Brisbane. Claire currently serves on several national advisory boards for digital health and is widely published in the field of clinical informatics. And now I pass it on to Claire.
Thank you, Amelia. Is it sharing? Can you see the slides?
We are having, yes, we can.
Great.
Yes.
Okay, thank you. So hello, everyone. It's lovely to be here. I must admit, Sean, I'm completely out of my depth with all the legalese there. So I defer to Sean's great knowledge in terms of the law. And despite me coming from a family of lawyers, I did medicine. So I'm not sure what that says about me here, but I'm excited to be here with you all. I would like to acknowledge the traditional owners and their custodianship of the lands on which we meet this afternoon and pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. And we recognise their valuable contributions to Australian and global society. And I'd particularly like to acknowledge First Nations' contribution to health, which is really the subject of my discussion this afternoon. So what is digital health? I like this very simple definition about any application of information communication technologies in order to improve healthcare and health outcomes. So today I'm going to talk you a little bit through what is digital health, how do we learn using digital health to improve healthcare outcomes, and then lastly, Amelia has asked me to give some examples of some digital health research. So we'll actually go through some of the research which is occurring here at the University of Queensland. So I'm not necessarily sure I will be posing any controversial policies or futures of policies, but I think my job is to explain a little bit around digital health. What are we doing with it, and what are some of the benefits and also some of the pitfalls? So that's what I'll be talking to this afternoon. I just love this slide because, it's the 1950s, and notice the nursing uniforms and the fact that they're selling cigarettes by the bedside. And the reason I always include this slide in talks like this is to remind me that much of the infrastructure and the ways of managing information in healthcare were set up at the same time this photograph was taken. So paper charts, scribbling, that happened in 1956 and it's still happening today. And these are the outcomes that we're seeing. So I'm not necessarily sure that the system we set up in 1956 is fit for purpose anymore when I can show you photographs like this. And I can guarantee that these photographs weren't there in 1956, but they're here now. So at the UQ Digital Health Research Network, we are looking to become a learning healthcare system where all the data entered during an episode of patient care is reused to improve the care of subsequent consumers. And this kind of idea from the 1950s about we only see people when they're sick, we charge them money then. The medical record is just an aid memoir for the doctor. It's not for anyone else. We don't ever monitor any outcomes, and research is not part of healthcare. That's kind of how things were set up in the 1950s. But I think from the photograph I've showed you earlier, that's no longer fit for purpose. And our consumers don't need to see us when they're sick. Often our consumers now have chronic illness and constant contact with them. That exchange of information between consumer and provider is the key to managing multiple chronic diseases and keeping people away from hospitals. So although I do love the clothes, I think our thinking needs to change. So we now collect rich clinical data on every patient every time in real time in digital hospitals. And we now have clinical informaticians or people like myself whose role it is to understand that information and to use it to improve care in real time. And that involves creating a learning healthcare system where the information that is captured during an individual episode of care has real value, not just to the provider at that point in time, but to manage and improve the outcomes of the system as a whole. And that idea can be a little bit challenging to very traditional doctors, it usually is, who believe that they own the information that they're writing in the record, and the only value of that information is to them themselves. Blocking the consumer from seeing that information and blocking other providers from seeing that information and blocking that information being used to improve the system. So how do we shift on from that 1950s thinking? And here at UQ, we're taking a very incremental approach where we're spending a lot of time and energy understanding how best to build digital workflows. So how do we replace the bits of paper and the faxes? And that's Horizon 1, creating digital workflows. Horizon 2 is around how do we safely and ethically reuse that data to create analytics which improve the system. And then Horizon 3 is combining the digital workflows and the data to create new models of care, such as using artificial intelligence, for example, to predict deterioration in chronic disease. So building these digital foundations can be really hard. And I'm sure you've seen, Courier Mail headlines about electronic medical record debacle and, these kind of headline things, because changing the way people have delivered healthcare for decades is really hard, and you will encounter a lot of issues as you shift. But we're doing a lot of work on how best to do that, and these are some of the publications from that area, and I particularly like this one, where we talk about the traditional approaches to changing the way people work and kind of modernising that with the idea of a complex adaptive system, and providers realising that the information that they're entering is valuable to others in the system, not just as an aid memoir to the provider. Horizon 2 is all around how do we take the data out safely, securely and ethically, and how do we use it to assist with improving patient care. And there's a whole host of ways that we can do that, and here's some examples. So during COVID, I'm sure many of you perhaps were affected by or saw drug shortages. And this is some work from our group where we actually looked at the number of prescriptions in diabetes medicines versus COVID events. So the purple line is during the pandemic and the other coloured lines are other years. And you'll see that when the first person died from COVID, we saw a massive spike in people rushing out and buying medications to stockpile them. And that caused shortages and panic buying and a whole host of distress. It didn't make any difference if you look at that curve to overall usage, but it was truly an emotional reaction by us all as people started to die from COVID. So we learned a lot from monitoring data in real time such as these. We're also working on how to actually predict patient deterioration for people who are hospitalised. And this review from our group looks at how can we take the data from the patient record and crunch it, if you will, to give early warning of patients who might deteriorate before they do so. Horizon 3 requires us to put those two things together. So the digital workflows, the data and analytics to create new models of care. And I will show you a few examples now of Horizon 3 work from University of Queensland. I'm very conscious we only have 15 minutes to get through all of this, so we probably don't have as much time as I would like to explore them, but happy to take some comments or questions at the end. During the pandemic, we certainly had issues with supply chain for PPE, and you probably all know that those supply chain issues to some extent still remain. So the challenge to us as the digital team is, could we think of some new and innovative digital ways to help supply protective equipment to healthcare providers? And I must admit, I didn't ever expect to be dealing with this. However, we did. So we used some software to download and 3D print face shields. This gave us the ability in Metro North to produce as many of these as we needed to. And we actually had a wonderful response from the community where we sent the software and the code out to people with 3D printers, and people and schools and shops were 3D printing these face shields and dropping them off at the hospital for us. In order to get these registered with the TGA, we had to go through a very exhaustive process, and this is just sharing with you, I guess, some of the work that we did in conjunction with Metro North, where we actually had to use a coughing machine to cough green slime at various team members there to see how effective our face shields were in order to register them with the TGA. And this really, I guess, demonstrates how we can start to use new and innovative models of care using digital technology in a way that in 1956 would not have all been imagined. Another example is how we can actually use the data that we collect during the pandemic to better drive a pandemic response. And this paper from our group really underscores the importance of connecting information and using it at scale. This is an application we developed called Decova, and I don't have time to go through the details, in conjunction with Queensland Health, that allowed the public health orders to be recorded, mapped, and for the hospitals to be able to predict how many admissions they were likely to get over the incoming period and how many intensive care admissions they were likely to get to help with capacity planning. Without this type of data being reused and analysed, our public health response would have been significantly more disorganised at the time. It's interesting, as our pandemic response has shifted and that type of data is no longer being collected, it's much harder. So yeah, it's been interesting to me to watch the change. We're now starting to use some of the lessons we've learned to plan ahead to the next pandemic. And this paper really talks through, now that we've learned some of these lessons, how can we use techniques such as electronic medical records, virtual care, to better equip ourselves next time that we're confronted with a pandemic like this. And these new models of care to me are infinitely interesting. They improve equity and they are safer. And safety is, I guess, a topic that's really important because we know that paper is unsafe. We know that scribbling a dose for rosuvastatin can also look like a dose for refliximab, for example. And there's no way to monitor the prescription and administration of those medications on paper. We know that digital prescribing reduces medication errors by about 40%. And this study published by our group looks at the influence of digital technology on improving and reducing errors in inpatient diabetes management, which is the 6th largest cause of serious adverse events in the NHS. This type of ability to improve care with implementation of technology was unimaginable in 1956. And when we do implement these technologies, we certainly see a sudden and step change in medication safety that is unable to be replicated by any behavioural interventions. That doesn't mean it doesn't come with new errors. So, of course, every time we introduce new technology, we reduce some errors and introduce some new ones. But overall, we know that it reduces medication errors. And I think that an interesting area for future exploration is the influence of storing genomic information digitally. And we've just published this in Genetic Medicine, where we talked about and thought about how we might actually store genetic information and start to use that in conjunction with the phenotypes that we see in electronic medical records to prompt searching for gene mutations which may provide early intervention or avoid death in people with genetic diseases. So an example might be if you had Parkinson's disease and you had your genome tested in 2020, and then in 2030, we found a mutation that if we gave you a particular drug, your Parkinson's disease would be stopped. With digital technology, we would have the ability to go back through the records to find people who had their DNA sequenced, to actually then resequence them to see if they had this mutation and potentially give them a life-saving drug. This type of thinking is very radically different from the idea that the paper record was an aid memoir to a specialist doctor and that information was not available to be shared or used by anyone else. Sean did touch on the concept of equity and cost in digital health. And we've just recently published this in Nature Digital Medicine because we're acutely aware of this also. We see that communities who cannot afford digital technology are not receiving it. And with the evidence I've showed you this afternoon, I think you'll understand that that means that they are likely to have more errors in their care. So is that ethical? How do we balance that against human rights? And this article really talks about the value of digital technology, how it's funded, and what does a value proposition that takes into account things like safety actually look like for government. Traditional business cases for digital health have been focused around financial return, and issues such as quality and safety have not all been costed or included in those business cases. And we would now argue that the safety implications of digital health are significant, have economic impact, and need to be included during the analysis. So that's a lot of information that I've shared with you there. How do we tie that up into the human rights discussion? I think that there was a lot of concern when I particularly started working in digital health that digital health was a place where my information was going to be sold or shared or hacked or in some way compromised. And the vilification of new technology is rampant. I hope nobody minds me sharing this, but the Clive Palmer party ran an ad on television last night saying that unless they're elected, artificial intelligence will end up controlling all our choices, and that they were going to ban artificial intelligence. So it was interesting that that vilification was framed as a frightening development in society, and I'm not entirely sure that they're across the recent data on safety to make that claim. So that's not to dismiss these concerns with privacy, they're real, but what's interesting to me is that they aren't necessarily always balanced with an understanding of the improvements in safety and quality that information sharing provides. And I suspect that's because this is not particularly interesting. Vilification is dramatic and exciting, and me saying that medication errors go down by 40% is pretty dull. So, you know, I guess when we think about risk and fear, we do see this type of reaction where the new technology is viewed with suspicion. But we also see this type of technology of reaction where technology is viewed with delight. And I think that's because human attitudes to risk are interesting. And we often have a large latent risk, such as us making repeated and profound errors in medication delivery, that we struggle to balance against the new risks of information sharing. So in some ways, we're more comfortable to sit with the fact that we are making prescribing errors every day than we are with introducing a new risk, such as using artificial intelligence, for example, to improve our decision making around that medication error making. So it's interesting to me that humans seem happy to sit with the latent risk and the mistakes we're already making, and are more suspicious about introducing a new risk, even if the latent risk vastly outweighs the new risk. So as the safety improvements and access and equity findings of digital health are released, it may start to become unethical not to use digital platforms and analytics. And I think having our consumers involved in that discussion and decision is just as important as having people like me. And I'll stop there. Thanks, Amelia.
Thank you so much. So as you pass on hosting to Ryan, I'm just going to introduce our final speaker for today, which is Professor Ryan Coe, who is the Chair and Director of Cybersecurity at the University of Queensland. Ryan has held senior scientific leadership, executive and directorship roles across industry and academia, and has more than a decade of board governance and advisory experience across government, industry and NGOs in Australia, New Zealand, Singapore and the USA. So yeah, I'm looking forward to hearing Ryan's discussion on digital health and human rights.
Thank you. I will need Claire's help to unshare her screen.
Ryan, I told you this could be hard. I need the cyber expert to help me out. Let me just see. I'll stop share. I see it. Yes. So sorry, Ryan.
Hey, no worries. Just a second. Can you see my screen? Okay, yep. So good afternoon, everyone. I'm Ryan Coe from UQ Cyber. I was just gonna give a quick intro, but before I do that, I want to acknowledge the traditional owners and the custodianship of the lands that we meet on today across the Zoom at the lands that which you are currently residing and dialing in from. Pay our respects to our ancestors and the descendants who continue cultural and spiritual connections to the country and recognize their local contributions to Australia and global society. In particular, I'm at the Yagara and Turrbal people's lands, and I want to acknowledge them as well. So just a quick overview of UQ Cyber. We are a group of about 60-something academics and their team of researchers and their students coming together from across several faculties, as shown in the middle box here, and Center for Policy Futures is also part of us. And also we work with industry, including not just the industry organizations, but also we have this AusCERT, which is Australian Computer Emergency Response Team, which was founded in 1992, second one in the world after Carnegie Mellon. So there's a bit of a heritage there to build on. We also do a bit of teaching with bachelor's programs and master's and PhD. So these are some of the areas that we cover, and these are some of the research that we currently are focusing on. Particularly of interest for today will be the center one, which is on data privacy and user control, which is also an area that I'm actively researching on. So these are some of the facilities that we have. We call it the Agile Security Operations Center, and this is a view of what we call the cyber war rooms, where we run simulations of attack and defense scenarios, both technical and tabletop exercises. I want to start our topic about human rights by just pointing us to this publication, which I'm sure many of you might have seen, which is in 2018, United Nations published an article about the human rights-based approach to data. This has also been a good validation for some of the research that I was suggesting since 2012 on the returning control of returning data control to users. So it covers some 5 or 6 main sets of principles on participation, data disaggregation, self-identification, transparency, privacy, and accountability. I'm going to cover a lot more on the last 3 because I think from a technical point of view, I'm a computer scientist. I'll try to complement the previous 2 speakers in these aspects. So from a computer science perspective, and this is quoting one of my past papers, we propose that data control, in order for us to have control over the data that we use in the computers and also on the cloud, we need to have 4 capabilities achieved. This achievement is not just in the technical aspects, but also in the policy and also the legal aspects. So first we need to know what happened to the data. I always use the example of my child in kindy. I want to know what goes on. I'm not going to micromanage the teachers, but at least I have a right to know what they are learning, and how much screen time they have, that kind of thing. Know what happened to the child, right? So, and then also preserve the privacy. So I choose the option of not letting my kids show up on public newsletters because I want to protect their privacy. And I think that's also an important part of data control for that aspect. And if something goes wrong, and touch wood, something goes wrong, you will be able to act upon it and revoke that situation. In the computer world, you could, sometimes some of the actions can be rolled back, and if you can, that's great, or if you can delete it, that'll be fantastic. Some of the examples are linked to like the right to be forgotten aspects of the GDPR, for example. And also the important aspect of maintaining business as usual. How do you get back to business as much as possible? What you're intending to do, or your aspirations and your goals. So if you can do that, and currently we can't all do that, when we use major cloud providers or digital health services, either one or all of the 4 factors are missing in most technologies. So if we can achieve all 4, I think we have pretty good control over our data in digital health environments. My presentation is not too much about an information, but more like to stir a bit of thinking and thought. So I want to challenge us. I remember in 2010, when I was working in Bristol, in the UK, we had this meeting with half the room was legal scholars and the other half were computer scientists, and we were basically debating about who are the gatekeepers of the digital space, right? And so we talked about the governments, they set the laws, and also the policies dictate what goes on and the impact of it. That's right. But at the same time, we have the the giant, or now called big tech, right? They are also kind of the gatekeepers. But one small group, right, which actually is the whole group of everyone. As long as you are a human, you also have the chance to be a gatekeeper. But the voice of the users as a gatekeeper is not very strong in this field. You usually will see that the technology is used and given to you, and you're given a wall of text to agree to in terms of user agreements. And most of us don't read it, before we say yes, because we just want to get to the content. And by that, we give up some of our rights as well. So there is a lot of avenue for us to be able to address some of these gaps as well. So this is one of the. So closer to the shores, in Australia, we have the Office of the Information Commissioner. They gave us pretty bleak statistics, but they're empowered because of the fact that there is a mandatory, it is mandatory to notify them if you have experienced a data breach, if you're an organization that holds data. So this is the definition of a data breach, right? So it occurs when your personal information is subject to loss or subjected to unauthorized access. Right. So, for example, if somebody was to have a work laptop containing medical data of some hospitals left in the train or on the bus, then that's a data breach, and it has to be reported. Or a database, for example, the Equifax, which was the credit rating company, lost millions and millions of private, information. Or, for example, if you send an email to the wrong person, that's also considered with the database of all the, maybe the X-ray details of a private citizen. And also, one thing close to my area in cybersecurity is that instead of phishing emails, most of the criminals nowadays, they leverage database breaches because it's out there, it's easy to get. So there are people who expose the username and password combinations. So, this is why we have multi-factor authentication. And they use this kind of breaches to get into your systems. So there's a lot of consequences in that. So interestingly, there is also the the process. So they have to notify the affected individuals, and also they have to inform the office through an online form. You need to be at a threshold of about a turnover of $3 million to be able to qualify for this. And if you make a turnover of more than 3 million, which is about a majority of the actual proper businesses nowadays, or if you're a charitable organization, you're obliged to do that. It is interesting to note, though, that it is not a crime to cause a data breach. It's not a crime to be the indirect or direct perpetuator of a data breach, but it is a crime not to report. So there is this policy interesting angle here, which I would consult most of the policy experts here. What do you think about that? Right? From a sector-wide perspective, from a report, so the last report was July to December 2020, published in 2021, and health service providers from the top. I'm not sure if this was because of COVID-19 in 2020, but the second in place was quite a distance away in finance sector. So it's something that is food for thought as well. One of my last few slides will be about the we have cloud data, and a lot of our private information are uploaded through systems such as Cerner and so on. And we do have laws and guidelines about whether we should keep things onshore, but how do we truly prevent them from being viewed or shared illegally without our consent, and there's no way to assure that right now, because in order for the computer to be able to process the information, let's say it's 1+1, or to understand that the text is ABC, the text has to be readable or processable. So it's definitely not encrypted when the processing is done. So how can we assure that the person working in companies that are providing storage or the processing of images, radiography images, are able to assure us that there's no breach or no misuse of the data? So there's no way we can gain that control at the moment, which leads me back to this slide again, but with this use case. So about 3 years ago, the radiography group were freaked out by this news that Israeli researchers were starting to show the capabilities to alter or add malignant tumor images into the the CT scans, for example, in this picture. So it brings me back to the 4 elements of data control. Are we able to achieve knowing what happened? So in research now we use provenance techniques. So I've been working on provenance techniques to track data changes at a very minute level, and that has helped us to trace things in other sectors, but not so much in healthcare nowadays, because the vendors in the healthcare sectors are also quite close. They typically wouldn't open up their systems, or they wouldn't be open sourcing their information. But we have tried that successfully in the finance sector, for example, and from some of the technology that I used to be involved in and we've contributed to have helped us to identify things like fraud or stop some of the criminal payments and so on. But we should be able to do that in digital health. So how do we prevent or preserve the privacy? In the encryption or cryptography research, we have this area called homomorphic encryption, which allows you to, for the data to remain encrypted 100% 24/7, but it can be processed by computers. However, for a fully homomorphic encryption, 1 kilobyte to do encrypting of 1 kilobyte of data takes 15 minutes. Right? So imagine one photograph which is about 3 megabytes. So that's 15 times 3,000 or something. Yeah. So that's the context, and that's why we have computer scientists working on trying to make it work better and faster. And there are also situations where we want to revoke things, but I don't see any immediate alerts, and if we have alerts like, oh, your data is being accessed by this cloud provider, do we want 1,000 alerts, every day? So there's this kind of alert fatigue that we have to think about, and also the business continuity aspects. Some research that I've done recently in the last 2 or 3 years would be in the proposing. I'm not going to bore you. This is not an eyesight test. Okay, so this is just to let you have a flavor. We're looking at how to improve privacy for machine learning in AI, which was mentioned by Claire. How do we preserve, the data when we are doing genome-wide analysis? This was made famous by Angelina Jolie, looking at using genetic probability to say that something might happen to her. And then also GDPR and so on. So with that, thank you, and I hope we're on time. Yeah.
Oh no, this is great. Thank you so much, everyone. I'll just put it on gallery so that we've got kind of a very nifty kind of Q&A discussion time now. So we've got a bit of a small group, which is really lovely. So I'd just like to open up to the floor and just see if anyone has any questions or anything. This is meant to be like an interactive kind of roundtable where we kind of discuss what does the policy futures of digital health look like and where people see this. And I guess, so yeah, I just wanted to open up to the floor and just see if anyone had any questions or anything from our presenters. I'm trying to do the, oh, we've got a question in the chat box. Brooke, do you want to unmute and ask, which might be easier than me reading?
Yeah, sure, no problem.
Thank you.
Hi, thanks to the presenters for the presentations. This might be more